Welcome to another episode of What Brings You In Today. I'm Taylor Fisher.
And I'm Kara Hope Hansen.
And we just want to thank all of our listeners for tuning in, subscribing, and leaving reviews for the podcast.
And if there's any topics that you're interested in hearing more about or any special guests you'd like us to have on, you can let us know at sgmc.org/podcast.
So today we're here with Kimberly Cross, MD, OB-GYN. So what brings you in today, Dr. Cross?
So I'm actually here today to talk a little bit about women's health and what I do every day.
Good. Well, we're really excited to have you. Can you share a little bit about your background and how you got into obstetrics and gynecology?
Sure. So I'm originally from, believe it or not, a small town in Cleveland, Mississippi. If you ever heard of the Delta, that's where I was born. I moved to Chicago, right outside the outskirts of Chicago, when I was 3 or 4, and that's where I grew up. My family was military. My dad was in the Army. After Chicago, I went to Xavier University of Louisiana in New Orleans, and that's where I obtained my bachelor's degree in biology. And it's funny, I talked to my mom yesterday. I said, how old was I when I really said I wanted to be a doctor? And honestly, from at a very young age, like 3 or 4, was when I knew I wanted to go into medicine. So I was super young. I loved my pediatrician. Her name was Dr. Berger, and I was fascinated by her lipstick. And Dr. Berger,
I love that.
Right? But she wore hot pink lipstick, and I always thought it was the coolest thing. She's a very jazzy lady. But also she taught me a lot just as a young girl about being a woman in medicine, and definitely empowered me from a young age. And so I went on to work for a little bit after college. Excuse me, I wasn't sure what I really wanted to do, and I wanted to make sure that medicine was for me. And I went back to Chicago and worked in pharmaceuticals for a couple of years, so I'm not going to give away my age. And I did a master's of public health at the same time. And at that point, I kind of knew this is what I wanted to do. And so applied for medical school, and I jet-setted to D.C., and I completed my MD at Georgetown University School of Medicine, and I stayed there for residency as well.
Okay.
You've been a lot of
I've been
different
everywhere.
places.
Yeah.
So a lot of people associate OB-GYNs with just pregnancy, but there's so much more to it than that. Can you kind of touch on some of those other key health areas in women's health that you are involved in?
Yeah, sure. So absolutely. I say we're 50% obstetrics most of the time and 50% gynecology, which a lot of people do forget. So obstetrics, again, is just taking care of, a woman from the onset of her pregnancy until delivery. But what I love is that we do also gynecology. And what, you don't really realize, but you take care of a lot of women from sometimes their first period, right, until they have a baby. And then when they go through menopause, and sometimes, throughout, that time. And so the gynecology piece deals more with menstrual periods, sexual health, a lot of mental health concerns as well. So I think we're kind of a hodgepodge of many things combined into one. But typically, most OB-GYNs do 50-50. We also do lots of surgical procedures. So with our obstetrics, C-sections, and with gynecology, we do lots of hysterectomies, other minor procedures as well. Mm-hmm.
And for some women, women are very busy. That may be the only time they go to the doctor is their annual visit or when they're pregnant. So y'all also kind of act a little bit as primary care.
Absolutely. For
women as well. And I know there's a lot of screenings and preventative things you can do. Can you talk a little bit about some of those key preventative steps and screenings?
Absolutely. So for most women, I do encourage women to, at least consider coming into a gynecologist around 16 to 18 is a good time. Not in particular for screens, but it's good to come in to kind of understand, your health as a woman. But your first screening is really at the age of 21. And so years ago, we used to do your first pap smear after you were either active intimately or, wanting to start birth control. but that is not the case, and it has not been the case for a very long time. So a pap smear is just a cervical cancer screen, and it is recommended to have your first pap at the age of 21. We see women every year, so we do recommend an annual exam. Pap smears are no longer every year. And if you read the new guidelines for screening, we do pap smears every 3 years. There are some caveats to that. Can also range to every 5 years for women in their 30s. But the next kind of big screening is and you're at 40. And so that's when every woman should have her first mammogram. If you have a family history of breast cancer, depending on that history and how old that mother or family member was, we would recommend mammograms possibly at an earlier age. There are certain immunizations that are important as well. But I know we're kind of geared towards screenings in your late 50s, early 60s. For postmenopausal women, it is recommended to have a DEXA scan, which is a bone density scan, and that checks for osteoporosis or osteopenia, which is low bone mass. I did kind of skip your colon cancer screen. And so the new guidelines for colon cancer screening is actually 45 for all women. It used to be 50. And so those 4, big screens are very important.
And what are, and we can talk about immunizations if there's any important ones that you want to talk about.
Absolutely. Definitely for younger girls. So, you may not necessarily come to the gynecologist for those screens, but the first vaccination from a women's health perspective is the Gardasil. You guys may have heard of that. We start that at 9 years old, and that would be at their pediatrician. You can actually have the Gardasil vaccine, which is the HPV vaccine, up until 45, and that's a new extension in age. It used to be 26, and then it was 44, and now it's 45. But it's a 3-shot series for younger girls and a 2-shot series for older women. And that would be kind of the first vaccination. There's obviously other vaccines that typically would happen with your primary care physician, but your flu vaccine can be done, honestly, at this point, any age. And your COVID-19 boosters. For our pregnant patients, we do recommend, if it's in the flu season, that they have a flu shot during the flu season. RSV is another important vaccine, and it's a newer vaccine that is important for our pregnant patients, and that is usually recommended between 32 and 36 weeks. And in addition, for our pregnant patients, the Tdap, and that's the tetanus, diphtheria, and the pertussis vaccine. That's for the whooping cough, and we can do that starting at 28 weeks.
Yeah, I think I'm due for that one.
And I got the Tdap at the request of my sister-in-law and brother because, they were having a newborn baby, and I wanted to be there to hold her. So just being extra safe.
Good.
How will you approach topics like birth control, menstrual health, and sexual wellness with patients who might be a little bit nervous, since those can be kind of awkward or uncomfortable topics for some?
Yeah, those are, they are uncomfortable conversations, I think, for some women at any age. I try to leave, I use kind of those called nonverbal cues. So it's very important, I think, as a physician in any specialty, kind of watch, a patient's, physical signs, and you kind of can tell where to take the conversation. I use a lot of open-ended questions, so I try not to do a lot of yes/no answers because it kind of closes a woman in on what she can say. For example, if I want to talk about, sexual health, I'll say, instead of, are you sexually active, what are your thoughts on, do you have any questions about your sexual health? And that then opens up sometimes Pandora's box, or, but, but you don't know where the conversation will lead, but it does start to at least give, just make a woman feel comfortable in that setting. I do also kind of like to normalize the conversation. I think we make some women feel very embarrassed, but this is what I do. So this is the place to talk about it, So I may try to, I joke a lot. You probably hear me laughing down the halls all the time. But I try to make patients feel that this is normal. This is what we're here to talk about. And I think that also helps to ease that conversation as well.
And full disclosure, Dr. Cross is my OBGYN, and I can attest to how comfortable she makes you feel in the room. Even topics like birth control, it's like, oh, have you ever thought about, this option, rather than like, what are your thoughts on, like, let's just do this.
Yes.
Making it a two-way conversation.
Well, thank you.
I think it's very important because, even as a woman in my 30s, it's still a bit awkward sometimes, but if you have that physician that you're comfortable with and this is literally their job, whatever question I ask, it's not going to be the craziest thing
Absolutely.
you've ever heard.
Like they've heard it all, seen it all.
Or heard and seen it all. Absolutely.
So what advice would you have for a young woman who's coming in for her first gynecological visit, and what should she expect, and everything like that?
I remember that being terrifying. Like the very first one when you're younger.
Yeah.
Oof.
It is scary. I think just to be, it's normal to be uncomfortable. And I think that is one of the things that is kind of the hallmark of any appointment with any patient of mine. You don't have to put on airs for me. You don't have to pretend like you're comfortable. It is okay to be uncomfortable. That's normal. It's not a comfortable exam.
Yeah.
It's I do recommend sometimes if you feel better with someone with you, that's always a good idea. Sometimes you're so nervous for that first exam, a lot of information kind of slides past you. And so it's okay to bring a family member, your mom, whoever brings that sense of comfort. Also know that you are in control of that visit. And so no physician ever should force anyone or make anyone feel uncomfortable with an exam. If it's something that is so terrifying and so uncomfortable or so scary, we don't have to do it. We can always come back. I do that all the time. And so, it can be whatever you want it to be. Know that with your first, exam, if you are 21, likely you will get a PAP, but you have that option to say, I don't know if this is, if I'm ready for this, and just kind of mentally being, in a space to prepare for that. I think it's a good idea to write things down. A lot of my patients do.
Yes, because sometimes you get there in the room and you have all these questions maybe you've been thinking about, but you forget.
Yes.
It's like, it's just good to have that note of like, oh yeah, I meant to ask her about this one thing.
I say, I always say women, we're so busy. We do so many things. We take care of everybody else. And it's, I know, my patients, sometimes it takes months to get an appointment. And so you're in this room and you may not be able to come back, write you could be in the car, Siri it, however you have to do it, tell someone to write it down for you. But it's good to come in with a list of things. Sometimes we may not have time to cover those things, but at least if there's something that you want to talk about, you have it with you.
Absolutely.
Yeah.
So one thing we wanted to touch on is we have a partnership with Life South Cord Blood Bank about cord blood donation. It's like an option that delivering moms can donate their cord blood. And if for somebody who doesn't know what that is, can you just explain it a little bit more?
Absolutely. So cord blood, it's just the blood that comes from the baby's umbilical cord. And we usually will collect that at delivery for various reasons. But this is something that patients can decide if you want to privately keep that cord blood, or you can do what's called public cord blood banking, and that's to donate the blood to families in need. In that cord blood, we have what are called, everyone hears about stem cells. It's kind of hard to know what is a stem cell. It's just a cell that can evolve into other things. Stem cells are early cells that can, potentiate or differentiate into different things. So different types of blood cells, different types of immune cells. And the cord blood can be given to people that may be dealing with things like leukemia, sickle cell disease, that need bone marrow transplants. So again, if you have a family member, I've had patients that have sickle cell, and they're, concerned that maybe their child will have sickle cell anemia. they can bank the cord blood on their own. It's kind of like life insurance. You can hold on to it until you think you need it. But you can also donate that. And when women present to labor and delivery here, they're asked if they would like to donate their cord blood. And we can certainly, it's a very simple process. They just literally sign a form, and that blood gets donated to a family in need.
That's awesome.
It's very, very important, and I'm glad we have that option here. So switching gears to a little more of obstetrics, how do you help your patients prepare emotionally and physically for delivery and labor and all of that? Do you have any words of wisdom?
Like, buckle up. No, I'm just kidding. I love my patients, and I try to keep some continuity. I think it's very important. I know it's frustrating for some women in pregnancy when you see, 4 or 5 different providers and you don't know who's delivering you. And I think from the beginning that having a sense of comfort and some continuity and knowing who your providers are is key. I think that one of the things, and the nurses may not love me for this sometimes, but I encourage birth plans. I do. I think the birth plan is really to open up a conversation and a dialogue about what your options are. There's lots of things that, it's hard to educate a couple on all of the things pregnancy. It's just so much. In a birth plan, there are multiple segments of a birth plan that starts a conversation about, do you want skin to skin? What is skin to skin? What is delayed cord clamping? All of these things. Do you want an epidural? Patients can then decide if they want a natural labor. Maybe we've never really talked about that before. Monitoring, what is that? And, I didn't realize I can have, the monitor and I can walk around a cordless monitor. And so I think education is key. I'm all about being prepared. I think the more prepared you are, the better. But there are things that you will not be prepared for. And sometimes the more you plan, things don't always go according, to that plan. But
yes.
I definitely try to add some sense of comfort and recommend, just being educated on what to expect. Mm-hmm.
Yeah, definitely. Yeah. And I'm expecting, so we have childbirth classes here at the hospital, and I recently took one of those with my husband, and it covered basically all from the beginning to end, to postpartum, and that was definitely eye-opening. So I'm definitely diving into the education and listening to podcasts and just trying to be as prepared as I can because I'm anxious about it. And I want to know what to expect. So I'm sure my doctor will start to go over those things with me as well. But I'm trying to be prepared.
Absolutely. Yes. You're going to do great.
And touching on that mental health, too, we briefly mentioned it earlier. But, I mean, how do you support patients' mental health, especially, maybe postpartum depression or anxiety?
That's a great question. So you hear about postpartum depression. Postpartum blues. So postpartum blues is really, it's common. Probably every woman experiences that. And that's, usually happens very early in the postpartum window, about 1 to 3 days after delivery, up to 2 weeks. And that can just be, due to crying spells, not feeling you're enough, anxious, but
not getting much sleep.
But usually with postpartum blues, the difference is that you can still function. So you can still do the things that you need to do every day to take care of your baby. What happens with postpartum depression, usually it's a lingering kind of postpartum blues that then becomes to the point where you can't continue to do those day-to-day tasks, isolation, crying much more than normal, feeling, defeated. One of the obviously big concerns is the suicidal or homicidal ideations, feeling like you may want to hurt your baby, things to that nature. And when it gets to that point, we do try to educate our moms on things to look for, and our parents, or the couple, so, their partner and other family members on what to look for. Women that have a history of anxiety, pre-pregnancy, or depression, they are at huge risk for postpartum depression. If they're on medications, a lot of times, it's not the best to stop those medications in the pregnancy. So, you want to talk to your doctor about what is safe for pregnancy. And definitely, if not continuing them in your pregnancy, postpartum certainly would be important to start those medications right away.
I was going to ask that about like certain anxiety medications. That is it better to just stay on it as long as it's safe for baby?
I think that there are times where it's scary a lot of times to know. Do you keep a woman on a certain medicine? Do you stop that medicine? But if you read all the literature, it is not good. It's best to continue someone on their medications for their mental health. If you abruptly stop a mental health medication on someone that's, in need, that can cause, can definitely cause mom to spiral, which then puts baby at risk. And so it's actually more important if that medication is safe, and you want to use your mental health providers or psychiatrists to really help intervene and talk with your OBs and just to confirm that those medications are okay.
And that kind of leads to my next thought, which was you hear about maternal mortality rates and maternal health, everything, and our rates are kind of high.
Yeah.
So in Georgia. Could you touch a little bit on what that means and what could be done? Because I think a lot of that is preventable, correct?
Absolutely.
If people are educated.
Absolutely. So we have one of the highest rates of maternal mortality in the country. And about 85% of the deaths that we have seen are preventable. That's huge. Yes. 85%. What we see are collectively, so mental health is one of the biggest, causes of maternal mortality, next to heart disease. And so these are things that we definitely need to, make sure that we're encouraging our patients to continue. Either we talked about medications, talked about, making sure do they have a mental health provider? Is there someone that they're locked in with that can kind of follow them through the pregnancy and make sure and check in with them? Are you doing okay? Do we need to change your medications? One thing that happens in pregnancy, your kidneys can filter a little bit faster. Certain medications start to become less functional, and so you may have to up those doses. So being, ahead of the game is important, but education is key. And I know that it does start with us as OB-GYNs, all of our, women's health providers, making sure that we are educating our women on that. It's super important.
And I've also heard about, when you go home from the hospital, that there are certain signs you need to watch out for that sometimes as women we might brush off, and we're trying to take care of this new baby. But they're like crucial things to watch out for. Can you talk about those a little bit?
Absolutely. So you want to watch for, especially with, mental health. So we talked a little bit about that, the postpartum blues and postpartum depression. From a cardiac standpoint or your heart health, if you feel any chest pains, having headaches, that don't go away. You can take a Tylenol or what have you, or ibuprofen, and it doesn't resolve. Having any shortness of breath, right upper quadrant discomfort is an indicator of some liver concerns. These are all signs of either postpartum hypertension or what's called postpartum preeclampsia. Is, some people think, oh, I have the baby and I'm good.
Yeah. I wish it were like that.
So that's not necessarily the case. Your body still thinks it's pregnant for 6 weeks after you deliver. And so you're still at very high risk for hypertension, preeclampsia, what's called eclampsia, and that's seizures. And so all of those things can occur if you have swelling. anything. If you just say, I don't know, but I don't feel right, call your doctor.
Yes.
Yeah.
And don't brush those things off
Absolutely.
because that is something they spoke about, which I'm glad they did in the childbirth class, was these are the things you need to look out for because maternal mortality doesn't just mean a pregnant woman. It's like up to a year after you give birth.
Yes.
I think that
Absolutely.
that still counts in that statistic. So,
Do you have any special patient stories that stand out to you that are meaningful?
You know, I really do. When you ask me that, I think every patient, it's hard to have any particular any story. I feel like I have stories with every patient. I love, sometimes being in a small town because I see patients, everywhere. And it kind of then brings, you see them in the supermarket with their baby and you think, gosh, 2 years ago they were trying to get pregnant and we were crying in the room. And then I came in with a pregnancy test and everyone was, happy. And I said, look, it's going to happen. Or the woman that was bleeding and, wearing diapers that now is so energetic and happy because we did a hysterectomy and, she feels better. It is hard for me to pinpoint any particular patients because I have so many patients that we have so many stories that it is a little difficult. I will say I have one patient that they had been trying to conceive, and the first time around they had seen another provider and then kind of saw me, and her, she was maybe a couple days late, not much, and I said, let's just check a test. And, I was almost in tears in the office with her and trying to figure out what to do. And I said, well, I'd had it in a little baggie. I said, well, guess what? I don't think we need to figure it out anymore. You're pregnant. I kid you not, they had the baby the next year. They had been trying to conceive for a year. She ends up coming in to see me to talk about fertility. And I said, let's just check a pregnancy test. I kid you not.
Again.
So I didn't get to deliver her first baby, but I said, I have to deliver this next baby. And that always, comes to mind. I have wonderful patients that have, had, we call them rainbow babies and have lost babies. And, definitely one in, sorry, I have stories.
No,
stories.
we love it.
One in particular that, wasn't having a cycle for years and thought she was menopausal, and we found out that there was a cyst on her ovary causing her periods to be suppressed. Took it out, got pregnant, lost their baby. However, got pregnant again. And she had a beautiful baby girl, and I get pictures all the time of her baby. And so many stories like that. It's definitely a rewarding job, I have to say.
Absolutely.
I would think so too. I mean, I'm sure at times it can be, a lot to deal with and emotional,
good and
but,
bad.
I just think if I were to ever go into medicine, which I never will, that would be one area.
Never say never.
I can't do blood. There's so many things I can't do. But I think it is probably a really rewarding and beautiful job to be there from the beginning to the end,
Absolutely.
the whole life of a woman's health. What is one thing, if that you can think of just one thing that you wish every woman knew about their own health or any piece of advice like that?
I think this goes back to that first appointment where, we talked about how you take control of that appointment. You are in control of your health. And everyone should feel some autonomy, meaning it is your body, it is your health. Women go through so much in our lives, and our bodies go through so many changes that we're so in tune. When a woman comes to me and says, gosh, something's hurting on this side, and it's been 2 weeks, and, I decided to come in today, trust your intuition. Know that, for women, I think we are some of the most amazing species on this earth. I think our instincts are beyond, and trust that. Trust that if someone tells you no, get another opinion. And so you are in control of your health and of your body.
Yeah, I think advocating for yourself
Absolutely.
is one of the most important things anyone can know about their health, not and men and women. But I feel like, especially as women, sometimes you feel like maybe you're not being taken as seriously as you think you should, because we do know. I mean, we are in tune with our body from the time that we are like 13, 14, and you have that first menstrual cycle, and you just know when something is wrong.
You know.
So.
You just know when you know.
Well, that's about all the time we have, but I have one more question.
Okay.
This is our favorite question to ask all of our guests. I'm sure that you're here a lot, all hours of the day, and we like to know what your favorite meal to eat here in the hospital is.
I hope the cafeteria is not watching.
Yep, the cafeteria or the allspice.
Okay, yeah, allspice is, I have to say, my favorite, and now I'm to the point where you walk down and they make this particular meal because they know what I like. It's the sausage, egg, and cheese breakfast sandwich.
I love that.
So
I bet you are here a lot of early mornings.
Yeah. Absolutely.
Well, thank you so much for being
so
here
welcome.
today.
Thank you all for having me.
This has been a great conversation. Thank you to all of our listeners for always tuning in, for subscribing, and please continue to rate, review, and submit your questions at sgmc.org/podcast. Thank you.
Thank you.